Let's discuss about upper GI hemorrhage. In the internal, I had a question lower GI hemorrhage. So I have covered in three parts: upper GI hemorrhage, lower GI hemorrhage, and obscure hemorrhage. Bleed proximal to ligament of Treats is classified into upper GI hemorrhage, and distal to the ligament of Treats is classified as the lower GI hemorrhage. Its incidence is 67 per 1 lakh people, and the normal daily blood loss is approximately 1.2 ml. When it is more than 10 ml, it is called occult bleed, and massive bleed when more than 1.5 liters per day occurs. The cause of the bleed is either variceal or non-variceal. It occurs in an 20 is to 8 ratio. The 80% is the non-variceal, occurring from the gastric or the duodenal ulcers. Etiology: the mucosal and structural etiologies are the peptic ulcer disease caused by H. pylori or the NSH induced physiological stress, the Cameron lesions, that is the hiatal hernia ulcers, post surgical anastomotic bleeds, iotoenteric fistulas. The vascular origin are the angiodysplasias, the triad Hyatt syndrome, aortic stenosis prevalent in CKD. The Dilophy lesions, dilated vessels erupting through the epithelium, and there is no primary ulcer. Systemic and medically induced antiplatelets or anticoagulants direct bleeding risk. Selective serotonin reuptake inhibitors impair platelet serotonin reuptake, and aldosterone antagonists. The false melena mimics medications causing melanocysia without actual occult blood. The iron, bismuth, and charcoal. Hematochezia, which is suggestive of bright red blood in stools or the brown colored stools, does not always suggest lower GI bleed. 10 to 15% it happens in the upper GI bleed conditions. The painless bleeding suggests diverticular disease, with pain suggests inflammatory or ischemic colitis. Change in bowel habit with weight loss suggestive of malignancy. Retching prior to emesis is suggestive of Mallory stare. The pre-endoscopic assessment by the Blatchford score. The purpose is admission triage. The parameters taken up are the blood urea nitrogen, hemoglobin, systolic blood pressure, BP, melena, syncope, hepatic or cardiac dysfunction. The crucial data: 1 is to creatinine more than 30 yields likelihood ratio of 7.5. The melanic stools yield a ratio of 25. The blood on nasogastric tube lavage has a likelihood ratio of 9.6. Blood clots in stools have ratio of 0.05, which makes upper GI hemorrhage unlikely. The post endoscopy, the Rockall score, bleeding severity and rebleed risk assessment. The parameters measured are age, weight heavily more than 80, shock status, systolic blood pressure less than 100, heart rate more than 100, comorbidities, endoscopic signs like blood clot and spurting vessels. Age less than 60, score is 0. Score 1 for 60 to 79, score 2 for more than 80, and for score 3 beyond 80. And for shock, pulse is less than 100, systolic blood pressure more than 100, it is 0. Pulse rate more than 100, systolic blood pressure less than 100, score 1. Pulse rate more than 100, systolic blood pressure less than 100 is score 2. The score 3 is for pulse rate more than 100 and systolic blood pressure less than 100. The comorbidities, the 0 comorbidities for score 0 and 1 comorbidity for score 1. For score 2, circulatory failure or coronary artery disease. Score 3, renal failure, liver failure, disseminated malignancy. Endoscopic signs of rebleeding: none or dark spot. For score 1, 2, 3, it is bled or adherent clot, visible or spurting vessel. For score 0, the diagnosis is Mallory syndrome or no pathology. Score 1 or 2 can be all other diagnosis. Score 3, suggestive of malignancy of the upper GI tract. Initial acute resuscitation protocols. Transfusion strategy. Restrictive strategy preferred for more stable patients. Initiate transfusion if HP is less than 7 grams per DL to lower all cause mortality. Transfuse 1 to 2 units if unstable despite crystalloids. Transfusion. Acid suppression by proton pump inhibitors. If there is active bleeding, 80 mg IV of the esomeprazole or pantoprazole is administered. If there is no active bleeding, 40 mg IV is given. H2 blockers do not reduce ulcer bleeding. Prokinetics like erythromycin 250 mg 20 to 90 minutes pre-endoscopically can be administered. It improves gastric visualization to 77%. It reduces need for second look endoscopy. The vasoactive medication octreotide 50 micrograms IV bolus plus 50 micrograms per hour infusion. It is standard for variceal bleeding. Prophylactic antibiotics like ceftriaxone are required for cirrhotics. Routine NGT placement is obsolete. No mortality or length of stay improvement is been noted. 15 to 20% of active upper gastrointestinal bleed patients have a negative nasogastric tube aspirate due to intermittent bleeding or pyloric block. Hematemesis or melena. Check for the patient vitals. If the patient is unstable, resuscitate and keep for observation in ICU. Then endoscopy is proceeded when the patient is stable. If the source is identified and if the source is not identified. If there is no source identified, then colonoscopy or the push enteroscopy, the CT angiography, video capsule are done. If the source is identified, then specific treatment is proceeded with. In stable patient, endoscopy within 24 hours is done. If the source is identified, then the treatment is proceeded. If there is no source identified, then further workup. If there is even still no source found, then laparotomy with intraoperative enteroscopy is done. The 24-hour rule, the standard upper gastrointestinal bleed is for stable suspected non-variceal ulcers, balances full resuscitation with timely hemostasis. And the 12-hour urgent rule is for the variceal. It is triggered by the stigmata of liver diseases or cirrhosis. High pressure systems demand expedited endovaricial ligation or sclerotherapy to prevent catastrophe. The diagnosis and the emergency protocol. When the initial esophagogastroduodenoscopy is clear but bleeding persists, massive unstoppable pooling, imaging salvage protocol, CTA, CT angiography, occult protocol, non-invasive, detects active arterial bleed as low as 0.3 to 0.5 ml per minute. The conventional angiography is diagnostic plus therapeutic. Microembolization can be done and requires at least more than 0.5 to 1 ml of blood per minute to detect and get treated. The right-sided colon trap, melena, usually implies bleed proximal to treats. However, slow transit through the right colon cecum or ascending degrade blood identically. So colonoscopy is mandatory if the esophagogastroduodenoscopy is normal. Small bowel or the no man's land. If upper and lower endoscopies are negative, immediately shift to capsule endoscopy or deep enteroscope to hunt for Crohn's, Meckel's diverticulum or the angiodysplasia. Forest classification, it is the endoscopic peptic ulcer rebleeding risk classification. Grade 1A, there is active pulsatile spurting. and the risk is 85 to 100%. Grade 1B, active non-pulsatile, that is oozing, it's seen in 55%. Grade 2A, non-bleeding visible vessel in 43%. Grade 2B, adherent clot. Grade 2C, ulcer with flat pigmented spot. Grade 3, clean non-bleeding ulcer bed is noted. Early endoscopy within 24 hours, routine second look endoscopy is not recommended unless visualization was obscured. The bleeding ulcer, 4 to 5% of are benign and are suggestive of adenocarcinoma or lymphoma. So it is must rule to excise or to take a biopsy. The gastroesophageal junction lesions, we should perform anterior gastrotomy and overshoot. If excision is mandatory, Cindy's procedure should be done to avoid catastrophic leak. In body antrum and the greater curvature lesions, wedge resection with primary closure, the mobile tissue is utilized. In distal lesser curve or in the incisura, distal gastrectomy is done. Hourglass deformity should be avoided. The bleeding duodenal ulcer. The duodenal ulcer exclusively erode the posterior wall into the gastroduodenal artery. The mechanism for the control is first one, the three suture ligation sequence. Step 1, anterior longitudinal duodenotomy is done for exposure. Step 2, figure of 8 sutures are placed at top and bottom of the crater to ligate proximal and distal gastroduodenal arteries. Step 3, use stitch under the center to catch transverse pancreatic collaterals is taken. Reconstruction. Hennig-Michelzeu pyroplasty is done closed vertically to widen outflow and prevent obstruction. Ligation versus the resection. Resection carries a high risk of duodenal stump leak due to intensely edematous tissue. Ligation with pyroplasty remains the safest emergency standard. Measuring the portal hypertension, wedge catheter is used, which creates a continuous fluid column with the hepatic sinusoids and accurately reflects the sinusoidal pressure. The normal is less than 6 mm. Variceal formation when it is more than 10 mm. Variceal bleeding occurs when the pressure is more than 12 mm of the mercury. The hepatic venous pressure gradient is wedged hepatic venous pressure minus free hepatic venous pressure. The variceal prophylaxis. The primary prophylaxis to prevent the bleed. Small varices plus computed tomography perfusion A. No treatment is required. Small varices with computed tomography perfusion B or C. Non-selective beta blockers are to be administered. Medium or large varices, beta blockers or endovaricial ligation is to be done. Secondary prophylaxis to prevent bleed, the standard is beta blockers plus endovaricial ligation. TIPS is recommended only if the patient rebleed despite pharmacological and endoscopic therapy. In acute variceal bleed, start vasoactives, then perform esophagogastroduodenoscopy. And once the variceal bleed is confirmed, then we either do endovaricial ligation or endosclerotherapy. If the bleeding stops, then drugs are continued for 3 to 5 days. If it does not stop, then mechanical rescue or TRIPS is performed, which is transjugular intrahepatic photosystemic shunt. The endoscopic sclerotherapy, the mechanism is intra or paravaricial sclerosing injection is administered. High complication rates of 10 to 20%, the severe stricture rate of 33%, it requires 3 to 6 sessions. The endoscopic variceal ligation, this is preferred. The mechanism is mechanical spiral bonding. Fewer sessions required, drastically lower stricture rate and lower recurrence rate. Sarin classification of gastric varices. The gastroesophageal varices 1, that is at the lesser curvature. The gastroesophageal varices 2, that is at the fundus. The isolated gastric varices at fundus is IgV1 and isolated gastric varices at any site is isolated ectopic. The treatment is cyanoacrylate glue injection. It is preferred over the endovascular variceal ligation for GOV2 or IgV1 bleeds. The BRTO, balloon occluded retrograde transverse obliteration mechanism, is it targets spontaneous gastrorenal shunts. Advantage is preferred over tips. It bleeds at lower pressure than tips, increases portal perfusion, and avoids encephalopathy. It is preferred over tips for IgV1 cases. The success rate is 84 to 100%. Tips, that is transjugular intrahepatic portosystemic shunt, is less effective for gastric varices than for the esophageal varices. The mechanical rescue bridge, the tamponates. The first one, the Sengstaken Blake mode tube. It is a triple lumen 250 cc gastric balloon plus esophageal balloon tamponade. Single gastric aspiration is present. Minnesota tube. It is a quad lumen 500 cc gastric balloon plus esophageal balloon. Two aspiration ports, gastric and esophageal, are present. The Linton necklace tube. It is a single balloon 600 cc gastric balloon only. Single gastric aspiration port. Balloons must be deflated after 12 hours to prevent esophageal necrosis. Tips. Absolute contraindications are the severe heart failure, pulmonary hypertension, acute liver failure, uncontrolled encephalopathy. The failures are the shunt stenosis, neointimal hyperplasia, it occurs because of that, encephalopathy in 15% cases, mechanism stent connection portal vein to hepatic vein bypassing the liver parenchyma. The surgical shunts, non-selective shunts, example the portocaval, mechanism completely diverts portal flow to IVC, produces exceptional bleeding control but accelerates hepatic failure and severe encephalopathy as unfiltered toxins bypass the liver. Selective shunts, DSRS, Warren shunt. It decompresses varices while maintaining hepatopetal forward flow to liver, disconnects splenopancreatic connections. Its advantage is that spleen preserving drastically reduces post shunt encephalopathy, superior for non alcoholics. Partial shunts. The mechanism is small diameter H grafts, HMM polytetrafluoroethylene, lower pressure just enough to prevent rupture, approximately 12 mercury size, while preserving hepatic portal flow. Devascularization, DVAS. The hemodynamic distinction. Disconnecting the system is devascularization versus depressurizing is shunting. Excellent mechanical control of bleeding without worsening encephalopathy but carries immense metabolic or perioperative risk. Strictly reserved as a salvage option for extensive mesenteric vein thrombosis. It is done by two procedures, the HACCP procedure, the Sugawara Futagawa procedure. The HACCP procedure, it is done by the abdominal route, devascularization of the upper stomach and lower esophagus with splenectomy is done. There is no esophageal transaction. In Sigura Futagawa procedure, transthoracic plus abdominal approach is taken up. Extensive devascularization plus direct esophageal transaction at the diaphragm. Mucosal layers are divided and muscular layers are kept intact. There is 100% mortality in emergency child C cases. The non-cirrhotic portal hypertension, it is by two mechanisms, the extrahepatic portal vein obstruction and non-cirrhotic portal fibrosis. Coming to the extrahepatic portal vein obstruction, it is seen in children. Portobiliary pseudocholangiocarcinoma sign is present. Pediatric stenting is done. Portal biliopathy, which mimics pseudocholangiocarcinoma. Pediatric stenting, depression of the hepatotrophic factors. The non-cirrhotic portal fibrosis, withered tree ultrasound appearance. Common hypersplenism in adults. Ultrasound features withered tree appearance, sudden cutoff of the portal vein branches. Pathology is Hilaire's four findings: hepatoportal sclerosis, periportal fibrosis, perisinusoidal fibrosis, nodular regenerative hyperplasia, venous outflow obstructions, Budd-Chiari syndrome, West thrombotic or myeloproliferative, East membranous occlusion or treat like stenning. Spiderweb intrahepatic collaterals are noted. In imaging, absent hepatic veins acutely, spiderweb pattern representing intrahepatic collateral formation are noted. In the veno-occlusive disease, it is triggered by Jemack-Bush T or stem cell transplants. Modified Seattle criteria, that is jaundice, hepatomegaly, or ascites or unexplained weight gain more than 2% are observed. The modified Seattle criteria time frame within 20 days of the transplant. Mandatory jaundice, serum bilirubin will be more than or equal to 2 mg per dl plus or minus 2 of the following: hepatomegaly, right upper quadrant pain, ascites, sudden unexplained weight gain, that is 2%. Pulmonary complications of liver diseases. They are of two types: hepatopulmonary syndrome, portopulmonary hypertension. The hepatopulmonary syndrome, the alveolar capillary bed are dilated. Intrapulmonary vasodilation is noted, that is shunting. Positive bubbles echocardiogram is diagnostic. Bubbles are seen in the left atrium 3 to 6 cardiac cycles post injection. Portopulmonary hypertension, the alveolar capillary bed is constricted. Pulmonary vascular vasoconstriction results in high pressure, leading to right heart failure. If pressure is too high, liver transplantation is an absolute contraindication. Summary. Summary. It can be done in four phases. As soon as the patient presents, resuscitate the patient. The phase 2, endoscopy needs to be done in less than 24 hours. If variceal bleed is suspected, it should be done in less than 12 hours. In phase 3, path A, in non-variceal or the ulcer bleed, target the endoscopy, assess the forest risk and plan treatment accordingly. The Sendis or the 3-point stitch. If endoscopic treatment is done, like clip application, thermal ligation or injection of scleropathy, it should be followed by proton pump inhibitor treatment. The path B, the variceal bleed is present, then endovariceal ligation and endosclerotherapy is done. Sangastic tube is used for mechanical rescue. Variceal banding first is the preference, followed by sclerotherapy as an alternative. If there is failure, then refractory rescue is planned for. In it, first we opt the tips: transjugular intrahepatic portosystemic shunt. It can be portocaval or splenorenal. In case of contraindication for TIPS procedure, we proceed for surgical shunts. In cases of failure of TIPS, we go for the devascularization, the last resort. The points to remember: restrictive transfusion when HP is less than 7 yields better outcomes. Melena indicates a bleed proximal to trees. in 90%. Selective shunts preserve liver function better than non-selective shunts. Bleeding gastric ulcers 4 to 5% are malignant, must always be excised or biopsied. The Delophes are no primary ulcer. They give gastroantral valvular ectasia, give the stomach a watermelon appearance. Cameron is ulcer in the bleed from the hiatal hernia. Thank you.